Thank you so much for joining us on It's Time today. We are your hosts. I'm Lindsley Donnelly, your citizen scientist and your longevity expert for midlife women.
And I'm Dr. Jen Wagner, physician and holistic performance expert. Welcome to It's Time, powered by Prosper. Just a quick reminder, the information discussed in this podcast is for informational and educational purposes only. We are not offering medical advice, nor are we entering into any type of physician or clinician relationship with listeners. Always consult your healthcare provider before beginning any new fitness, nutrition, or lifestyle changes to ensure they're right for you. Your health and safety is our priority, and let's keep it that way.
Hey, it's time. I'm so glad to be back with all of you. I'm sorry Linz and I are still not together. Believe it or not, we are going to be back together one day soon. Got my cool Summit bags behind me, giving out some extra holiday gifts this year from Summit. If you guys haven't checked them out, remember they're a cool outdoor brand, friends of Lindsley and I, SMMT. They just dropped some super cool holiday stuff. So go check them out. Today, I just wanted to take a few minutes and talk about what a historic couple weeks that we've had for women's health and what do these things mean, and hopefully clear up some things that may be adding to the confusion. So for those of you that may have not heard, just about a week and a half ago, the FDA removed the black box warning on menopause hormone therapy. So what does that mean? If we go way back to 2002, prior to 2002, there were tens of thousands of hundreds of thousands of women taking hormone replacement therapy. That's what we called it at the time. They were taking a combination of usually conjugated equine estrogens and medroxyprogesterone acetate, or MPA, as their progestin. Then came in 2002 the Women's Health Initiative, which gets a bad rap. The Women's Health Initiative was an important study that a lot of good findings came out of. But unfortunately, the data around the breast cancer risk and hormone therapy was probably inaccurately analyzed, and then the media got a hold of it. And overnight, hundreds of thousands of women stopped taking hormones, and a whole generation was never even offered them. So let's go back and review that study about what really the study was designed for, what the findings were, and why it has taken us 23 years to get this black box warning removed. So the Women's Health Initiative was really designed to look at cardiovascular disease and hormone replacement therapy. So to do that, because we know cardiovascular disease happens more often in older women, they picked an older cohort or an older group of women to study. Women in the Women's Health Initiative, on average, were 63 years old. Some of those women had never been on hormones. So some of those women were started on hormones at age 63 because they wanted to see what the cardiovascular, if there was benefit or risk from hormones. And so they had to start participants at an age where they were likely to develop cardiovascular disease. So then came this idea out of the combined arm. So those taking estrogen, and it was conjugated equine estrogen, and a progestin, which in the study was medroxyprogesterone acetate. And that's important because those aren't the hormones we often use anymore. It was found that there was a slight increase in breast cancer. So let's talk about this. The risk of breast cancer in the non-hormone arm was 3 out of 1,000. The risk of breast cancer in the hormonal arm was 3.8 per 1,000, which is the same amount of increase we see with obesity, we see with age. So that is the data that stopped all of these women from having hormone replacement therapy. So I think that's important to understand. And in fact, in the estrogen only arm, they actually saw a decreased risk of breast cancer. So what did we learn from this? We learned timing matters, number one. Number two, we learned distance between menopause and the initiation of menopause hormone therapy is important. And number three, we learned the type of hormones we're using are important. So years and years and years of reanalyzing this data, experts convening with the FDA. And I know many of you probably don't spend time watching the YouTube FDA channel. However, the hormone discussion is fascinating. If you have 15 minutes, I totally recommend you sit down and watch it. They have a group of amazing experts in women's health really going through the risks in layman's terms. Like I found it really, really interesting. So plug to FDA YouTube channel if you have 10 or 15 extra minutes and really want to understand all of the science that has come since the Women's Health Initiative and why we felt it was so important to get this black box warning removed. I highly recommend you check that out, and we'll put a link to that. So what happened about 2 weeks ago now, and was super exciting for me because I was in Lenox at Canyon Ranch hosting a menopause retreat with the amazing and incredible Tamsin Fidel when this news erupted. And I was fortunate enough with the Prosper team to be in DC in early 2023 and present to Congress on the current state of women's health and performance. Obviously, Tamsin has been to DC many times and has been pivotal in just really diving into women's health and menopause and making these conversations normal and bringing to light and attention that this topic deserves. So it was super special to be with her when this news broke out. And so what happened was the FDA removed the black box warning on menopause hormone therapy. So what is a black box warning? If you ever get a prescription, and women are much more likely to do this, if you ever grab a prescription and pull out that big pamphlet inside of it. For hormones, until recently, there was a big black box on it that said, be careful, these cause cancer, these cause heart disease, etc. And so that did a couple things. It really scared women, rightfully so, right? We're trying to do what's best for ourselves. We don't want to inflict harm. And it really scared physicians, right? Who take an oath to do no harm. So what happened is there was this element of fear connected to this specific form of treatment. So a whole generation of women were never even offered it because we automatically assumed that the risks outweighed the benefits. To the point that as a physician training in this period of time, we were never taught how to prescribe hormones. So I know there's a frustration right now that women cannot find providers, but this is why. It is this ripple effect from this inaccurately analyzed science that has rippled into how physicians have been educated and how women have received treatment for over 20 years. So now that black box warning is gone, except for the endometrial cancer risk. And that's important to understand. So what does that mean? So when a woman has gone through menopause and they are no longer making estrogen and progesterone on naturally, and we supplement it, if a woman has a uterus, an intact uterus still, they have to have progesterone because unopposed estrogen supplementation will cause the endometrial lining to thicken, just exactly what happens before we had a period. As hormones would be released by our bodies, the endometrium would thicken in preparation for implantation of an egg. And when that didn't happen, we had a period. With unopposed estrogen, that endometrial lining likes to thicken. So that's why women who have a uterus must also take a progesterone of some sort. And we can talk about the different options there. So that's really important. So that warning is still on estrogen related products. And it's good to have it there because that is a risk. And it's important for women to know that if you have a uterus and you're taking exogenous or external estradiol, you need to have a progesterone. Now, you can take oral progesterone, you can have a progesterone IUD, and there's risks and benefits to both of those. But the big scary black box warning about breast cancer and heart disease has been removed. So what do we hope are the outcomes of this? Number one, that women feel more confident going in and having a conversation. You do not need to suffer. We know that hot flashes and vasomotor symptoms, so hot flashes and night sweats, increase the risk of cardiovascular disease and maybe, we're not quite sure, maybe increase the risk of dementia later on. So if you're having very bad hot flashes, it's actually a sign that maybe your vascular system is a little different, leading to heart disease earlier. And so treating those hot flashes is important. Hormones are the best treatment, and it's one of the FDA indications for using menopause hormone therapy. The other thing is for our bones. So 1 in 2 women will have an osteoporotic fracture in their life. 25% of those women that fracture require long-term care. 50% of those women that never return to the mobility pre-fracture. And there's a 20% increase in mortality in the first year after fracture. That is devastating. So again, we know that estrogen is so important to our bone health. And that is another FDA approved use of menopause hormone therapy, is to prevent bone loss. So the other benefit of that black box warning is hopefully a confidence in physicians to have a conversation with women. And we've removed that fear factor that was there inappropriately. This doesn't mean that all women can take hormones. This doesn't mean that all doctors are going to feel comfortable prescribing hormones. My true hope in this removal of the black box warning is that both women and providers feel more comfortable initiating the conversation to see if that's the right therapy, because women have been suffering for decades. We are moving away from smallest dose, shortest time frame to actually seeing the benefits of putting women on menopause hormone therapy early. So what does early mean? Early means within 10 years of your last menstrual period, or that day, because remember, menopause is one day. One day. It's the day on the calendar, 12 months from your last menstrual period. And then the rest of the time, we are in menopause. And so we need to start hormones. We know it's safer to start within a 10-year period of that day and below the age of 60, which usually correlates within a 10-year period of that day. We know that for women who have early menopause, whether it's surgically induced or natural, starting hormones early is very important to their cognitive health, their musculoskeletal health, their metabolic health, and their cerebral health. So my biggest hope, again, with the removal of the black box warning is that women feel empowered to have a conversation with their physicians because they understand the risks, and that physicians feel empowered to have a conversation with their patients so that women no longer suffer and actually can receive the benefits of being on menopause hormone therapy. So let's go back again and just revisit a couple things. Current state today. We no longer use very often the type of hormones that were used in the Women's Health Initiative back in the early 2000s. Today, we use what are called bioidentical hormones. And that word can be really confusing. So what a bioidentical hormone is a hormone that is chemically identical to the hormones that your body produces. So you can get bioidentical hormones from the pharmacy that insurance pays for. You can also get bioidentical hormones from a compounding pharmacy. One is not better than the other. And in fact, many people will say the hormones that you get from a normal pharmacy have to meet FDA requirements, and there's a lower risk of contamination and other issues that can happen from a compounding pharmacy that is not as strictly regulated. But that being said, you can get a bioidentical hormone with a prescription from your doctor for a regular pharmacy or from a compounding pharmacy. So what are the two bioidentical hormones that we use? Estradiol, 17-beta estradiol, is the estrogen form. That can come in a cream, a gel, a patch, or oral. So lots of different ways to take it. There are benefits and risks from all of the different preparations. And so for some women, oral estrogen or oral estradiol is a better choice. That goes through the liver. So women who have a history of clotting and some other issues, it's probably not the best choice. For women that have high cholesterol, it might be a better choice. So again, have a conversation with your healthcare provider. The beauty of a compounding pharmacy is sometimes women that are not tolerating a gel, cream, or a patch, it may not be the estradiol itself. It might be something in the adhesive or in the substrate that's binding the estradiol together in the cream or the gel. And so the compounding pharmacy has the benefit of being able to kind of customize those formulations. So there are pluses and minuses to each. And then we're using a bioidentical progesterone as well. The biggest, and again, who needs progesterone? A woman that has a uterus who is deciding to take menopause hormone estrogen therapy. We have to add the progesterone in. Progesterone, again, is really calming. So some people even start with that before they start with estrogen if you're feeling like anxious and overwhelmed and maybe not sleeping well, because that's actually the first hormone that we see a sustained drop in, usually before we see a sustained drop in estrogen. It can be a little bit sedating, or it can make you a little sleepy. And so we recommend that you take your progesterone at night. Almost everyone takes progesterone orally. It's very well tolerated. There is, again, some people, the sedating effects of progesterone, they just can't tolerate it. And so then there are alternatives like a progesterone IUD that goes into your uterus and provides progesterone locally, but you get very low systemic absorption with that. So those are a couple of ways that you can take progesterone. Then if hormone therapy is not right for you, or you don't want to take hormone therapy, but if you're suffering from what we're calling the genital urinary syndrome of menopause, which is vaginal dryness, pain with intercourse, frequent UTIs, possibly incontinence, there's vaginal estrogen. Now, vaginal estrogen is almost safe for everyone to take because it is not systemically absorbed. And if you are using a vaginal estrogen, except for if it's a contraceptive dose. So if it's like the Femring and some other, if it's contraceptive dose, that's a different topic. But if we're talking about menopause hormone therapy with like a vaginal estrogen cream, there is almost zero systemic absorption. So you also do not need a progesterone if you are just using vaginal estrogen. This is probably the best treatment. Vaginal dryness, recurrent UTIs, studies have shown it's better to use vaginal estrogen than antibiotics, pain with intercourse, and incontinence. So that is another conversation to have with your healthcare provider if you're suffering from those symptoms. So now the question is, how long do we stay on it? And I think this is an active area of research. We're now seeing women stay on hormones for decades. We know when we stop them, a couple things happen. The bone density preservation and or gain that we've had goes away within about 6 months. So if you have a high risk of osteoporosis and genetically, body habitus, lifestyle, that you're prone to osteoporosis and you're on hormone therapy, important probably to stay on it. Cardiovascularly, we know when started early, it is actually protective. We know that there are cardiovascular derangements during menopause, meaning cholesterol shifts, change in our vasculature. And so again, continue to monitor with your healthcare provider, but probably safe to stay on it. And then the cognitive benefits as well. So again, these need to be conversations that are personalized, specific to your needs. You know, your doctors need to know, do you have a personal history of cancer? It's really important to know, especially hormone sensitive cancers, blood clots, dementia, cardiovascular disease, osteoporosis. All of these things can help determine whether hormones are the right decision or not, and then how long to stay on hormone therapy. So it's not a one size fits all. And then the last thing I want to say about this is it's also not perfect out of the gate. So please don't get frustrated if the first dose or the first even mechanism, maybe you start with a patch and that's not the right delivery mechanism. It needs to be an active conversation with your healthcare provider. And there is a titration period. Maybe it's too high at first, maybe it's too low. We don't have good lab values to follow until someone is in menopause and we have kind of a baseline. Because if you remember from some of our previous conversations, prior to that, hormones are all over the place. Estrogen's going up and down crazy. We don't know where we are. We didn't have a period for 3 months and then we had a 2-week period the next month. And so it's really hard to predict where we are until things level out. So once they're leveled out, we can titrate hormones based on labs a little bit more accurately. But before that, it's really hard. So sometimes there is a little bit of trial and error, especially if you're in your perimenopause period and your body is still making some endogenous hormone. And so sometimes your estrogen might get too high and you might need to back off your dose, or sometimes you might feel like things are too low and you need to up your dose. So anyway, work with your healthcare provider and just realize that there might be a little bit of give and take and titration and adjustment. And then the last thing I want to touch on is testosterone. So testosterone is still not FDA approved for women. However, many providers are prescribing it for women kind of off label. And testosterone can do a lot of things. It can help with fatigue, low libido. It can help improve body composition by increasing lean mass. So testosterone is a hormone that just kind of decays slowly with age, both in men and women. So we can follow levels. It's not cyclic the way our estrogen and progesterone are. So it's worth having a total testosterone and a free testosterone tested, especially if you're having symptoms like that. Overwhelming fatigue, difficulty putting on lean muscle, low libido. Those can all be secondary to low testosterone. And if that's the case, testosterone replacement, again, this is off-label use and you have to work with your provider. You can get it from a compounding pharmacy. You can titrate out a men's dose, which is usually about 1/10 of a normal man's dose of a gel that you can put on. There's lots of varieties of ways to take it, but it is worth having that discussion, just knowing that that is still not an FDA approved hormone for women. So I hope this little recap is helpful. The biggest news is hopefully women are empowered to have this conversation now because the fear is removed. And my hope is that practitioners are more engaged in this conversation because the inaccurate fear is removed. Again, if you're looking for a provider, check out themenopausesociety.org to try to find a provider in your area. And there are online providers like Alloy and MIDI that you can do telehealth to help find if there's not a provider in your local area. So I promise Linz and I are going to be back together soon. I hope you guys are all doing well, and thanks for listening.
Thank you so much for spending your time with us here today. If you liked what you heard and you got some tips on how to live better right now and for the long haul, Please help us reach more midlife women. Please share and rate and like this show, and we can't wait to continue the dialogue with you on our next episode. Until then, thank you. It's time.